According to the World Health Organization, depression is the fourth leading cause of human suffering and disability. Why? Not because we don't know how to treat it, but because most people who need help aren't getting it. Tonight, we're going to talk about depression and how to get that help. Next on the season premiere of Speak Your Mind. Welcome to Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with the Human Development Center, and tonight we're taking your questions on depression. Now, this is a call-in talk show, which means you, the viewing audience, have a job to do. So call the numbers on your screen right now. Locally, dial 218-788-2844 or call toll-free at 1-877-307-8762. And you can also text us your questions or email them using the number or address listed at the bottom of your screen. Let's start by introducing our guest. Dr. Latina Else is the lead psychologist with St. Luke's Mental Health Services, where she conducts psychological testing and provides psychotherapy to a wide range of clients. Dr. John Glick has been a staff psychiatrist at the Human Development Center for the past 20 years, where he uses a combination of psychotherapy, traditional and complementary medicine to help the clients he sees. And Susan Mullinex works at Choice Unlimited as a job coach, teaching skills and blending support to her clients. She herself has struggled with depression. Thanks to all of you for being here this evening. And I think a really nice place for us to start, Susan, if you could start the evening off for us by telling us the story of your own journey through depression and how that started for you.
I don't know when it started. It wasn't until I was 40 years old that I realized that I was actually depressed. Prior to that, honestly, I just thought I was a I tell people that, but it's true. I would just, it wasn't a chronic depression. The depression would come and then it would go. And I would be fine and life is good, and then I'm not fine and life is not good. And I thought I should be able to just talk myself out of this and exercise and eat right and think good thoughts. And when I couldn't, that just increased my, I guess, low self-esteem, the struggle. It just made it worse for me.
And were you working during this time also, Susan?
Oh, I lived my life. I went to college, I worked, I married and had children, yeah.
And so how, now eventually you got help for the depression. How did that come about?
I was in divorce counseling actually, and the counselor told me, you have got too much to deal with while you're depressed, and prescribed something that actually worked for me.
And when the counselor said you have so much to deal with, and mentioned the word depression, because there you were thinking, and I'm going to use your words now, not my words, that you were a was that the first time that you had even conceptualized that maybe depression could be the problem?
Many years earlier, I was given, prescribed something that did not help at all, and so that was the end of that.
And then when you, after this divorce counseling, or through this divorce counseling, you went and you got some help, and through the course of that, you were prescribed some medication, and that medication actually was helpful
Yes.
for you. And then what was the difference between your life sort of before help and then after the help?
It was amazing. I didn't struggle. I didn't hurt. I mean, I still have moods. There are good days and there are bad days, but I realized that painful, twisting, not okay was gone. And it was amazing. I just kind of looked around and said, do people actually live like this? This is possible. And I realized that I don't have to go there anymore. Prior to that, I didn't know. It was just a part of my life. It was something that happened to me on a regular basis. There was nothing I could do about it except get through it, try not to cause any more damage to relationships than is absolutely necessary.
And, I think, Dr. Else, Susan described herself as experiencing herself during her depressed times, and we're kind of making light of this now. But I don't think it was light then. Describing herself as being like a, which to me sounds a little bit like being more irritable than depressed. And so let's talk some about the symptoms of depression.
Well, certainly. I mean, one of the, of course, hallmark characteristics is either that feeling of being down or depressed or low, but for many people it's irritable, agitated, grouchy, thin-skinned. That's such the hallmark feature of that condition. And I imagine the other things came along with it as well, the problems with concentration, focus, not being able to really keep your mind on things very long or have the efficiency that you had before. Problems with sleep and appetite are typical. Again, some people sleep more, some people have a lot of insomnia. I mean, not liking the things that you used to like. Things aren't as fun as they used to be. You're going through the motions. Mm-hmm. Some people have thoughts of suicide, not wanting to live, or maybe it's more of a passive thought about just not wanting to wake up. Some people feel really sluggish, slowed down, like they're walking through molasses, or they just can't seem to, they just feel draggy and down.
And I had read this statistics that there are many different symptoms of depression, and we just heard you talk about many of them, and you don't need to have all of them to be considered depressed, do you, Dr. Glick?
No, but with most depressions, you should see either sadness or loss of interest in usually pleasurable activities as a core feature. And I think the other core feature is just a loss of that vital sense of energy for most people with depression. There are some depressions where people feel more agitated as though they have too much energy, but it's more common to just feel that loss of your vital energy. And when we diagnose depression, we look for a period of 2 weeks where somebody's felt that way most of the time, and we always want to be sure it's not a mood change that's due to the effects of chemicals or substance abuse or to a medical condition. And once we've ruled those things out, then we're more comfortable talking about depression.
We have a caller who called in, Frank from Duluth, asked, how do you know if you have depression? And I think, I don't know if maybe what Frank is asking, what is the difference between, say, having the blues and having the normal sort of depressed feeling that we all get from time to time versus the illness of depression?
I would say it's more of that for depression, it's really more persistent. I mean, that mood just tends to go with you. A friend and I were talking about the difference between grief and depression. In grief, all the rest of the rest of your life is the same. But in depression, it's like it just comes along for the ride all day long, and that's one of the ways you can sort it out. It is hard to self-diagnose.
And I would add to that that to diagnose a mental disorder, we usually like to see one of two things. Either the condition is making it hard for the person to function in their life, and that might be work or social functioning, school. And if that's not there, we at least want to see that it's a distressing condition to the individual and making them suffer. And so there's a severity there that has to be there to cause a certain level of suffering or impairment in the person's life.
And Susan, what was your experience? You just heard Dr. Glick say both impairment in functioning and suffering. And let's start with suffering. Was that part of your experience with the depression?
It physically hurt. It physically hurt inside. And I slept hours and hours and days away. It took a real determined effort to do what I have to do. I remember one time I lived in a cabin, I had wood heat, and I was in bed depressed. And I knew I had to get up and put fire in the wood, or wood in the stove. I had to put wood in the stove. And I couldn't make myself do it. But I knew that if I didn't, the fire would go out. Then I'd have to start all over with the kindling and the paper and get it started, and that would be much more difficult. And I was afraid. I was afraid because if I can't make myself stoke the fire, it's going to go out and it's going to get very cold. And what's going to happen to me?
And you know, I think when I'm working with my own clients, one of the coping phrases that I give them to kind of get going and to get doing something is that get doing anything really is there's nothing wrong with my bones and muscles, which kind of gets at what you were saying, which is that it feels physically that it's not that it's an I won't, but it's that an I can't.
I can't. And suicide was always an option. I always believed that was an option if it got bad enough. And I considered all the different ways I'd do it. If it hurt bad enough.
Here's Carl from Proctor said, I had a stroke 4 months ago and lost interest in a lot of things. Is this depression or will this go away? Dr. Glick?
Well, it certainly could be depression. I'd suggest Carl talks with his doctor. People can get depressed after a stroke because of different reasons. It's obviously a difficult stress to deal with and the changes that are brought about by the stroke, and then sometimes there can be changes in the brain that can trigger depression too. And I think it's important to treat depression in the context of a stroke because there's some evidence that by treating the depression you can actually help the recovery from the stroke as well. So that would be good for him to talk to his doctor.
Let's start talking a little bit about the treatment of depression because we don't want to just say that there's an illness here, that we also know that there's help for the illness. And Latina, let's talk about some of the strategies that you would use in helping somebody with depression.
Well, there are different treatment approaches that have been shown to be effective. Cognitive behavioral being a treatment approach that I often use, which is helping a person with the thoughts that contribute to and maintain depression, working on restructuring them, changing certain behaviors, trying to increase those movements, trying to find some things that someone might enjoy doing, getting good social support. Those are good strategies. Interpersonal therapy is also helpful, which is focusing on the relationships that a person has. And so those are, but all good therapy really is based upon getting to know that individual. I mean, that relationship between, the therapist and the patient really has to be a good one, and to listen well to what that individual's story is and find those elements in there that's associated with the healing. But again, there are these approaches that do work, cognitive behavioral, interpersonal, mindfulness-based approaches are showing some good results in the literature these days.
And one of the things that I have seen in my own work is that often people who, especially if they've had depression for a while, if you've had the illness for a while, one of the things that starts happening is that you don't just have the illness, but now that begins to create other problems in your life, where you may be having problems in relationships because of the depression, or you kind of look knowingly when I said that, Susan, or you may start having problems at work, and that part of the therapy is also to help rebuild and patch up and make good on those areas of functioning, I think, that the depression is affecting. And you even made a comment, Susan, that when you started feeling better, you started working back toward on relationships and mending some relationships.
Yes, because when I was so depressed, everything was so not okay. That, well, you might be tempted to just run away and go try something different, or try to make it okay when that's not what's wrong. You know, it's inside of me, and I can't, nothing out there is going to fix what's happening inside of me. So you're just kind of trying all kinds of things that don't work.
Yes, yes. Dr. Glick, talk to us a little bit about maybe the medication side of depression.
There's many antidepressants available, and most of the newer antidepressants are fairly safe and fairly easy to take, and often quite helpful. I think it's often the case that a medication alone doesn't remove all the symptoms of depression. Sometimes it might, but it's often the case that combining some therapy approaches with medication is the best.
And in fact, I have a question here from Susan in Duluth, who says, I have depression, but I'm allergic to lots of pills. What else can I do to treat my depression? So aside from medication.
Well, Latina was talking about therapy, and therapy has been shown to be as effective as medications for mild to moderate depression, and actually to have the benefit of giving you some protection against relapse, which you don't have when you stop the medications. So therapy can be a really good option.
I found that the medication put me in a situation, put me in a state to where I could get benefit from those other things.
Yes, like Dr. Glick is talking about, it's the mild to moderate depression that the therapy helps the best with. If your depression was at that severe level, it's hard for therapy to really do enough to get you rolling, and that medication on board really has to, is an important key. So it does work together well.
Absolutely, and I know some of the newer research is showing that exercise can be a huge benefit for people who, it can be a huge benefit for all of us. We all need to be out there exercising for many reasons, but research taking a look at exercise's effect on depression, and with, I think, some of the newest research showing that especially for people who have that depression where you're very lethargic and you don't have any energy, I think kind of the trick is getting those people to get out and exercise.
I've got an idea for that, Carol, and I think these step counters can be really helpful. They're pretty inexpensive and widely available. 10,000 steps is supposed to be equal to 5 miles roughly, although it varies for the individual. So a person can get a step counter, see what their baseline is, and then try to increase it from there. That can be a good way to get some exercise.
I think that's a wonderful idea, because now we're talking about somebody of, even if you're only doing 50 steps a day because you're so severely depressed, the goal instead of being 10,000 maybe is 55 steps, and you kind of go from there, piecemeal and piecemeal. We're kind of heading into that time of year. I don't think we're kind of. I was thinking there aren't going to be very many Thursdays where I drive to the station here and it's still light, where we're losing the daylight, and then that brings to my mind seasonal affective disorder. Let's talk a little bit about, first of all, how is seasonal affective disorder, maybe Dr. Glick, I'll start with you on this, how is seasonal affective disorder different from general depression?
Well, it can look very similar. The symptoms, the typical symptoms are what have been referred to as the hibernation response, wanting to sleep a lot, eat a lot, crave carbohydrates, low energy, really feeling that complete drain of energy from your body. And of course, it's seasonally linked, getting worse in the fall and typically better in the spring.
And what has been your experience with people with seasonal affective disorder in terms of what has been helpful for them in treatment?
Well, if possible, trying to get them out during the natural sunlight. That doesn't work for all people for various job types that they have. But if people are able to do that, that helps them the most. I mean, because you're combining increasing your activity level with that natural sun exposure. antidepressant medications, activity scheduling, and lightbox therapy, which seems to be more and more common and easier to access, whereas 5, 6, 7 years ago, light boxes were $300+ now you can get a reasonable one for about $50 online.
And I think that they're getting to be more and more covered by insurance as well.
Yes.
Well, yes and no. I've actually been having a harder time recently getting insurance companies to cover it, but SAD, or seasonal affective disorder, is a big problem in our area. 6% nationwide, probably close to 10% in our area. Light therapy is very effective. It's the intensity, it's not the wavelength. We typically use white light. It's often a fluorescent source, and you want to use it early in the morning. And you can go to Amazon.com and pick up the Verilux Happy Light, for example, for about $150. It's a really excellent box. Use it a half an hour to an hour in the morning. Be careful if you have eye conditions. Consider consulting your physician first. But it's very effective.
And so then, Dr. Glick, people who use lightbox therapy, is that somebody who would, in addition, be prescribed medication, or would this be an either-or?
Well, it's often both. As Dr. Else mentioned, light boxes help. Antidepressants, and in particular serotonin boosters like Prozac, Zoloft, and Celexa help. Exercise helps, and cognitive behavioral therapy helps. So we often do end up combining if one alone isn't enough. And by the way, this is a good time to start using your light box if you have SAD. Yeah, use it early to try to prevent it a little bit.
Mike from Hibbing writes, depressed people often feel suicidal but fear being incarcerated for their own protection. How is this approached to avoid the person bearing suicidal thinking from their therapist?
Well, it isn't necessary to lock someone away that has suicidal thoughts, but it is necessary to make a plan to keep them safe. And, you know, again, knowing that individual, getting to know them and trying to work with them on what would be a plan of safety for them. You know, maybe it's, you know, spending some time at a friend's house, or maybe it's having a phone check-in, or, you know, I mean, learning that individual circumstance. So I would hope that they don't have the experience that the second they say suicide, the therapist is calling the police. I mean, that shouldn't be their experience, because there's lots of different things that can be done to be helpful.
And I think the other point, too, is that a lot of people have suicidal thoughts, but how risky and dangerous they are to themselves really ranges quite widely, even if you're having those thoughts.
Right.
Some people only have the morbid thoughts where they wish they were dead, as opposed to I want to kill myself. And sometimes even, I think it may be important for the viewing audience and for this person to understand that even talking about that with a therapist could relieve some of the suicidal thinking as well. We have another question here. Anne from Duluth asks, what therapies are available for depression that don't include medications? And you mentioned a few. You mentioned the mindfulness space. I don't know if people know what that is quite. Maybe you could explain a little bit what that is for folks.
Well, that isn't necessarily a therapy that I offer, but we do have an individual at our agency who does actually a mindfulness-based depression group, and has had excellent success with that group. And again, it's using meditation. It's using a frame of reference to help you, I would say, kind of disconnect from some of those thoughts in a way, might be a way to phrase it, versus cognitive therapy, which is restructure the thoughts and rewrite them. This is more coexist with them. And so it's just a different approach that seems to be very helpful for a lot of individuals.
And Susan from Carlton says, how can a family or friend help someone they think is depressed? Since you're a Susan from Duluth.
I was from Carlton.
Oh, you were? What suggestions might you have?
Boy, I don't know, but as you were talking, I was sitting here thinking, intervention. You need intervention, because I have honestly compared when the depression is bad enough to ask that person to get help is similar to asking someone with a broken hip to walk to the phone and call for help.
Yeah.
You can't do it. You can't do it. You can't just take care of yourself.
So literally saying, are you all right? Can I help? How can I help get you the help you need?
And I'm wondering, you know, I'm amazed now as I think of the years that I went through that. And when I was really super depressed, I isolated. I would not reach out. I was not going to subject anybody to me during those periods. And then when it eased, well, then it was okay again. So as you were,
we need to wrap up. So
Okay.
I need to cut you off here.
Okay.
I'm getting the sign, or we're going to go to black. Thanks again for all of you for being here. Don't forget to visit us on the web at speakyourmindonline.org, where you can find a schedule of the topics we will be covering this season, find helpful online resource links on tonight's topics, and read my blog, the place where I answer more of your questions that I didn't get to tonight. You can also email us your questions about next week's show, when we'll be talking about parenting teenagers. I'm Dr. Carolyn Phelps. Thanks for watching, and good night.